Thanks, Dr. Glee. So, good morning, everyone. Yes, it's a very diverse topic, and the time is limited, so I'm going to start off straight off the bat. I wanted to look at the clinical relevance of using genomic detail to guide us in our management of prostate cancer, and I've gone across the board. I'm starting with localized prostate cancer, and I'll switch into metastatic and CRPC in the second half of the talk. So we know, obviously, that prostate cancer is a predominant oncogenic disease. It plays a major role also in Canada. We have a lot of deaths from prostate cancer, but there has been a progressive improvement in actual fact from the death rate of around about 3% per year over the last 2 decades. And that's due to improving our testing methods and the ways we approach and treat our patients. And so it's important to say that prostate cancer is definitely not our father's cancer. Back then, diagnoses were made at a very late stage, very often. Surgical capacities were limited, and there were complex surgeries with many risks. And the management of metastatic disease was very blanketed. And as we've progressed with the introduction of using screening like PSA in the late 80s and into the early 90s, and surgical management changing over time, we've improved the way that we approach the disease and the management of it as well. And especially now in this day and age, with the development of genomic landscaping of disease, this helps us to guide some of the management in disease, and I'll show you what I mean with that. So first of all, with the introduction of PSA and then using that as a screening tool, there was the early establishment of risk classifiers to try and stratify patients in the localized prostate cancer setting for the risk of recurrence of disease. Now, one of the first that were introduced was in 1993, published in Journal of Urology, looking at department tables. These incorporate the PSA, Gleason score, and clinical stage to assess the extent of disease in a localized setting. So what is the risk of the disease going beyond the prostate, involving the seminal vesicles and lymph nodes. Following that, in 1998, was the introduction of the D'Amico scoring system that looked at Gleason as well. It looked at PSA and it looked at clinical stage to grade patients into the risk of biochemical and disease reoccurrence within at a 5-year cutoff period. And it was assessed into low, intermediate, and high risk. And for low risk, it was around about 25%, between 25 and 50% for intermediate disease, and then above 50% for those patients that were categorized as high risk. And it's very unspecific in the extent that it doesn't incorporate age, it doesn't incorporate cultural differences and heritage for those patients. It doesn't include the extent of disease that is involved, and it doesn't show any areas of interest within the prostate as well, which are important aspects that I'll get to as we go down the road. With the incorporation then later down in 1999 of the Catan scores, there was a little bit of variation into risk stratifying patients with localized prostate cancer, including the Gleason score, but also the number of cores that were involved and age, which was previously not done. And so to try and assess whether patients, what the prostate cancer specific mortality was related to management of localized prostate cancer was very difficult, because these details that I've mentioned before have sort of been vague and not able to give us the insights that we need. And so in 2005, there was the introduction of the Capra School, which took again a little bit more detail into their consideration, as you can see. So with the biopsy results, they were listing the number of cores involved, and age again played a role as well. But again, it showed similar results to the Catan score, and did give us information with regards to projected information with regards to biochemical reoccurrence of disease, but that isn't necessarily an adequate surrogate for prostate cancer specific mortality. And so there was a very interesting study that was published in 1994 in the Journal of Urology, looking at the heterogeneity of the architecture of prostate cancer to give us a better impression of how this disease is defined within the organ itself. And so the study looked at 101 whole-mounted radical prostatectomy specimens, and what they demonstrated was there were multiple grades of Gleason score within, or Gleason grades within the prostate whole mounts, and they were heterogeneously distributed without any predictable geographic location. So it shows us that there's a lot of diversity within the disease of organ-confined prostate cancer as we know today. And so the next step up was basically to have a look, and this was an interesting publication reflecting on, again, the 5-year biochemical reoccurrence of disease in localized prostate cancer, but from a genomic point of view. And so when we recall back, the NCC guidelines that we use to risk stratify patients are very similar to the D'Amico score that was established back in 1998. So with the genomic information, this showed a very interesting aspect. They subclassified patients according to the genomic details that were established in the study. And they could show that patients in a specific, was stratified into a specific sub-cohorts, 4 different subtypes. And one of them was quite interesting, actually, was a subtype that was called, that had very few genomic alterations, and these patients had a very low risk of disease reoccurrence, irrespective of the initial diagnosis in terms of risk stratification that we use in the NCC guidelines. And so the next step up from there was looking at the genomic detail within localized prostate cancer again, a little more detailed in this aspect. It was a very small study, only looking at 4 specimens. But what it showed was the genomic detail is very heterogeneous. In actual fact, the heterogeneity within each individual cancer foci in the prostate is different to those located in other foci within the prostate. So there's an intertumoral heterogeneity as well as an intertumoral heterogeneity in localized prostate cancer, which shows that there's extreme diversity, and maybe the way that we are structuring patients in terms of our clinical management doesn't reflect what is truly happening within the prostate. And so just to give you a general insight, on the image on the left is when one of the first next generation sequencing analyses was done looking at localized prostate cancer and trying to subclassify the genomic profile of prostate cancer in the localized setting. This was one of the first summaries that came out back in 2011, showing that there were these ETS, so E26 rearrangement alterations. A very big component of that is a particular fusion rearrangement, which is called TMPRSS-ERG, contributes to about 50% of localized prostate cancer. That overlaps with some genomic changes that trigger a lot of pathways that I'll try and introduce to you today. And then very separate of that was a so-called SPOP mutational change in some localized prostate cancers. And this was 5 years later, 4 years later down the road with the TCGA and analyzing localized prostate cancer. They subclassified it more specifically. And so there are 2 main groups, ETS positive localized prostate cancer and ETS negative localized prostate cancer. And the ETS positives contribute to about 60% of localized prostate cancer types. Of that, about 90%, so 50%, are ERG2 positive, so have that TMPRSS-ERG fusion alteration. And there are other pathways that are also connected and featured within this distribution of localized prostate cancer, like the PI3K pathway, as well as P10 and P53, which are typical tumor suppressor genes that obviously trigger pathways once they are knocked out or altered due to mutation. And then there's a second group of localized prostate cancers that are defined as ETS negative. They tend to be separate of each other. So, for example, SPOP, which contributes to about 15% of localized prostate cancer, cannot have a FOXA1 mutation. So that sort of separates those two and divides it into another subclass. FOXA1 I'll talk about as well. IDH is a very rare form, so I won't go into too much detail on that today. And again, there are associated features and pathways that may play a role in understanding how the localized disease has aggressive or less aggressive components when we're talking about maybe structuring patients in terms of managing them genomically. And so to give you some details, this discovery was made back in 2005 with this particular fusion. It's a series of genes really that regulate cell proliferation, cell cycle regulation, angiogenesis and apoptosis, and one can understand obviously if there are changes in ETS, then this may cause cells to proliferate uncontrollably and then initiate into prostate cancer development. And as I've said before, when we look at ETS positive prostate cancers, which contribute about 50% of localized prostate cancer, the majority of those are Tempus-ERG positive as well. And so there were some studies looking at this published in the European Journal of Urology between the time period of 2009 up to about 2014, looking at the prognostic indicators that might show us which patients are at risk with regards to this newly discovered genomic landscape. And so the results are very conflicting. And some studies that showed that patients that have an ETS positive and ERG positive localized prostate cancer have very aggressive disease. It might be indolent. And they have a higher risk of progression. And some studies showed the exact opposite. So you have an early diagnosis of the disease if you have an ETS positive prostate cancer, but it is less aggressive. So in summary, we're not quite certain what these details actually mean. And there were other studies looking that are listed up below. We're looking at different populations. They were looking at a population-based study with watchful waiting, and obviously those patients do have a poorer prognosis, and so there's some bias there in that information that we've gained from that insight. Another series was looking at patients that underwent radical prostatectomy, and those studies showed conflicting results again. So some patients were doing well, others were doing worse. Now, can we use the information that we've gained to gain further insight into the risk of disease? And this is an interesting study looking at using Tempus-ERG as a urine biomarker after you do a DRE on a patient to detect whether there would be prostate cancer and maybe guide the decision-making towards doing a biopsy or not. The study did show that Tempus-ERG has a very good specificity, and it's about 90% or 93% by itself, but it's not very sensitive. It's only around about 30% sensitive. If you use it in conjunction with other factors like PSA, and for this particular study it was important to have PSA below 10, and another urine marker called PCA3, that sensitivity rose up to 80%. So we could show by using this genomic analysis that you could possibly define prostate cancer without having done a biopsy at all. And so one of the other pathways that I wanted to talk about, which is in conjunction with the ETS positive prostate cancer that I've mentioned before, is the PI3K pathway. And this is a pathway that I need to spend some time on because we will be coming back to this pathway multiple times in today's talk. And so it's important to see the PI3K is that little pink marker on the bottom figure on the right. It's obviously a very simplified way of looking at the pathway and how it is regulated. One very important component that is missing there is P10, which sort of blocks that little pink molecule. And as you can see, if it's activated, it activates a pathway that activates ATK, mTOR, and then possibly the initiation of androgen into the cellular nucleus, which then translates into transcriptional data from the AR pathway. So there's a very close conjunctive function between PI3K and the AR pathway. Now, it is present in about 30% of localized prostate cancer that is ETS positive. It's found in animal studies to be present in high-grade PINs, so that's a sign that this is an alteration that occurs very early in the development of prostate cancer. And obviously it is affected by multiple other pathways and mechanisms that are associated with the development of tumorigenesis, including P10 loss, which is a tumor suppressor gene, or TP53. And so if those are switched off, then obviously this pathway, as I've shown looking at that little pink spot, will activate and possibly lead to development of prostate cancer. And it's found enough relevance in actual fact, that it has been converted into a phase 2 study at the University of San Francisco in conjunction with Novartis for a particular PI3K inhibitor for patients that have high-risk localized prostate cancer prior to going on to have an RP, a radical prostatectomy. So there is enough interest in these pathways for the pharmaceutical companies to actually go into development of drugs to try and change the management of these genomic details. Now I'm going to switch gears because we've spoken about ETS positive localized prostate cancers, and we've spoken about PI3K pathway, which is conjunctive with that. On the other side of the coin, there are obviously, which contributes to about 40% of localized prostate cancer, are ETS negative prostate cancers, and we've subdivided those into SPOP mutational changes and FOXA1. SPOP contributes to about 15% of localized prostate cancer. And as you can see, this Cell publication that came out very recently in 2017 sort of tries to explain how this mechanism activates two particular pathways. And so we've spoken about PI3K and we've spoken about AR, and the top half of the figure on the right shows that if the SPOP wild type is not mutated, there's no change, then these two pathways work in a negative feedback mechanism. So when the one's activated, it deactivates the other pathway. If there is a change, and it seems like when there's a change in the SPOP mutation, mutational change in SPOP, it activates both pathways simultaneously. And so there's been some debate and hypothetical analyses trying to understand how this can be relevant for us in the management of prostate cancer. And two things were found. In this particular study, because there is a lot of activity due to the activation of both pathways, the AR pathway, so androgen receptor pathway, and the PI3K pathway, which we saw sort of mounts into activating the AR pathway in a secondary mechanism, there's a lot of transcriptional information coming from the AR. And so one of the ideas is to manage SPOP prostate cancer with androgen deprivation therapy, as it might respond very well. Another aspect that's been shown is that SPOP mutations cause a deficiency in DNA damage repair. And so if you have DNA damage repair, you're susceptible to drugs like platinum therapies, like carboplatin or cisplatin, also PARP inhibition. And so the hypothesis is that one could theoretically use these drugs to manage patients that have this particular subtype of prostate cancer as well. And the third aspect that I wanted to talk about, or the fourth aspect actually, in conjunction with ETS negative prostate cancer in the localized setting, was the FOXA1 subtype, which contributes to about 5% of primary prostate cancer. And FOXA1 is involved in the maturation of the prostate during puberty, it seems. It has similar molecular structures like SPOP. But the exact clinical relevance in the end is not quite clear yet. So we don't know how to use the information that we gain from these genomic analyses to guide us in a clinical approach into managing prostate cancer. One thing I can say to that is that it has a very particular docking station. So if you look at how it activates the AR receptor, it docks on the hinge binding domain of the androgen receptor, which is the figure on the top right, and then helps the transportation communication in terms of DNA transcriptional information from the AR once it has reached the cellular nucleus and attached to the DNA segments of interest. And so there are two other very important pathways that play a role, particularly when we're talking about metastatic castrate-resistant prostate cancer, but that need mentioning at least in the localized setting as well. That is, again, the androgen receptor pathway, because it plays a major role once the disease has spread beyond the prostate and has become metastatic, and in particular when it's become castrate-resistant. Because it's one of the main pathways that we obviously use clinically to manage prostate cancer in the way that we do androgen deprivation therapy and AR-targeted therapies. It's hardly altered in primary prostate cancer, interestingly. So as the disease progresses, there's a shift of the AR and an activation of the AR pathway to a certain extent that I'll discuss once we talk about prostate cancer in the metastatic setting. But it seems to be altered in those patients that have a very early onset of disease. And the other very important aspect is what we talk about when we speak about DNA damage repair genes. There are some very important DNA damage repair genes that we know about and that have a significant impact on those patients that are found to have mutational changes, particularly in the germline setting. And those are BRCA1 and 2, obviously, ATM. There are a whole bunch of other ones that we can talk about, which I won't go into too much detail today. But from a clinical pathological point of view, we know that patients that are BRCA positive for mutational change in the germline setting have an early onset of disease. They have a more aggressive disease. And there's a risk of early progression and obviously of a worse outcome. And so it's important to try and identify patients of that nature, and using genomics to do so, to guide us in our way of managing is the future of precision oncology. And so there are a couple of tests that I wanted to talk about that use genomic detail to help to guide, again, clinical aspects and show the certain relevance that is associated with the genomic information that we are able to gather with the techniques that are available to us today. So one of the tests in particular is called Prolaris. It has a 46 RNA-based gene panel that investigates tissue biopsy. So it's a tissue-based test. So either tissue biopsy or radical prostatectomy specimens. There were two big publications, one in the British Journal of Cancer and the other one in the Journal of Urology, looking at the outcomes of patients to predict the cancer-specific mortality of patients that are diagnosed with localized disease. And again, that's one of those, when we're talking about the risk stratifiers that I mentioned before, the clinical ones that we used before, they don't have the sort of specificity that we can gain with this. So these two studies show that prostate cancer specific mortality can be determined using the Prolaris test. It can be used to determine the biochemical reoccurrence and metastasis-free survival after radical prostatectomy as an independent predictor of those aspects of management of prostate cancer. And it was actually first introduced at the AUA in 2014, and it was looking at the mortality risk involved in prostate cancer, and it was shown that it was more predictive, in actual fact, than the Gleason score, PSA, age, clinical stage, and all the factors that we use at the moment to try and determine which patients are truly at risk. And there were two other interesting, one is a study, the other one is a trial that's taking place at the moment, and this is trying to assess how clinicians redefine the way they will manage localized prostate cancer in patients once they have the additional genomic information. And so these are patients with low-risk disease in a localized setting. And in addition to this information, the physician is given information with regards to the genomic profiling after the Prolaris test. And it changed a significant component of those patients that we would normally consider to be good active surveillance candidates. So nearly half of them, the approach in managing them was changed in this particular study. And it had gained so much interest that there is this ProProve trial running at the moment. It's still accruing. And it's, again, a questionnaire-based study trying to find out if the genomic information from this test changes the way the clinician guides the patient in managing his localized prostate cancer. And there's a second tissue-based test. It's called Decipher. It uses 22 RNA-based genes to look at a similar sort of profiling. Can we better profile our patients in a localized setting? It was presented at ASCO GU last year in Florida, and so one part of the study. And what they were looking at was the genomic analyses of biopsy specimens to classify patients to predict metastases and disease-specific mortality. And what they showed that was in high-risk patients, the risk of developing metastases in about 5 years is around about 23%. And so if we go back and we look at the classifiers that we're using at the moment, a high-risk patient is considered to be at a risk of recurrence of disease of above 50%. So that's quite a significant change. And the risk of cancer-specific mortality for a high-risk patient is around about 9%. And this study, published in Prostate Cancer, looks at how the Decipher score altered the risk stratification of Capra scored patients. So the Capra score was highlighted at the bottom, what is considered low, intermediate, and high risk. And the colored bars indicate how Decipher had reallocated patients. So those patients that were considered to be low risk in the Capra score, of them, 30% were considered to be high risk using the Decipher test. And again, in the intermediate cohort, a similar sort of number. So it just demonstrates that the way we are structuring our interpretation of what how to risk stratify patients might not be adequate enough. Genomic information does give us a lot of detail that was previously not available. And so this is, again, these are two studies published, one published in the JCO, the other one in the European Urology, looking at using this test to determine the risk of patients developing metastases at a 10-year cumulative incidence rate after radical prostatectomy, and the decipher characterized patients with low risk of having a risk of approximately 5%, those in high risk around about 25% of developing metastases after 10 years of definitive management. And so again, the decipher score in summary shows that it has a better predictive value when it comes to prostate cancer specific mortality than many of the other straightforward risk stratifiers that we're using in a clinical setting at the moment. But what does this all in conclusion say about localized prostate cancer? Well, localized prostate cancer demonstrates obviously a lot of heterogeneity. We've shown that with not just with the pathological architectural studies that I showed back in 1994, but also with the genomic detail in the studies that I've shown after that. So intratumoral and intertumoral diversity within the prostate is prominent. There are a multitude of mutations and copy number changes and alterations that reveal genomic complexity, which I've also shown to a certain extent with the subclassification of localized prostate cancer through the TCGA. Subtyping of the disease and using classifiers to predict possible disease recurrence and progression can be useful, as demonstrated in some of these publications. But does it really give us an answer to the question that we have? How well can we actually reclassify our patients and manage them accordingly? That is difficult. It's probably in its infancy, its early days. But it seems to show promise. And now I'd like to switch gears. I want to talk about the genomic landscape in metastatic prostate cancer, and in particular, looking at how we clinically manage these patients, as we are very much focused on the AR pathway. The drugs that we use, like enzalutamide, abiraterone, and apalutamide, are all drugs that focus on AR targeting, and so that plays a very major role in the way we define and clinically manage our patients if they have spread of metastatic disease. And in particular, once the disease has become castrate resistant. There have been some changes in recent times, looking at different settings, as we know from the studies, Latitude and Stampede, looking at the use of abiraterone in a very early stage of disease, and also more recently in disease where we have biochemical CRPC, but we don't have any signs of metastatic spread, with the use of enzalutamide and apalutamide to manage prostate cancer. And so, as there is a lot of heterogeneity in localized prostate cancer, there's even more heterogeneity from a genomic landscaping point of view in metastatic disease. So it's a lot more complex. There are a lot of other pathways that are intertwined. And so due to the time limitations of this talk, I'm going to focus on three main pathways. The AR pathway, which is important in today's clinical management of metastatic disease, but I'll also talk about PI3K because it's an important pathway that is very closely associated to the AR pathway. And I'm going to talk about DNA damage repair gene defects because that's, again, something clinical and relevant that we use today. Other pathways that are involved are complex, and for the sake of this talk, I won't go into those. So looking at the disease just to see the transition from localized prostate cancer, where the AR doesn't play a major role, across to metastatic disease is actually nicely shown in the left-hand part of this figure. So we've got those subclassifications that we spoke about, ETS positive, and then the ETS negative, which include SPOP, FOXA1. And then there are those genes that play a very important role in tumor suppression, and if those are mutated, changed, like TP53 or P10, that sort of triggers the pathway to the disease becoming independent and the spread and increasing the risk of spread of disease. And as there is change into metastatic disease, we know that there is a lot more mutational change taking place, and the genomic stability changes as well. And so this slide is to try and demonstrate what I was saying before. In the localized setting, on the bottom left-hand part of the figure, there is a lot of heterogeneity and localized disease. It's difficult to clearly define what is driving the disease into the metastatic state and which metastases are those that are driving the disease. So the gold standard to date looking at metastatic and CRPC disease from a genomic point of view was to do biopsies of metastases. Those are very invasive, they're costly, and they might just give us an insight of what's happening in that one particular metastasis that is being investigated, but there might be multiple metastases that are actually driving metastatic disease, so it's not just one in particular. And these alterations can be due to manipulations. It's either a selection bias due to the manipulation of drug management when we initiate ADT management, or for other reasons that are not quite clear to date. And so one of the pathways that I wanted to talk about was the AR pathway, so androgen receptor pathway. And as we said, it wasn't very prominent in localized prostate cancer, but it is very prominent particularly in CRPC. And it's altered in the majority of cases. There's a lot of amplification because the manipulation of our management of that disease using androgen deprivation therapy, the number of AR is exemplified and amplified. And there can be all sorts of changes to the androgen receptor itself as well, which is important to know because of the instability in genomic alterations in the AR, and we'll get to details of that in a minute. So the changes that can occur, the androgen deprivation drugs that we use to manipulate the AR can alter and cause mutations where that drug that we're using to actually break the disease is actually causing it to accelerate. And so there are a couple of hypotheses how this comes about. One of them is looking at post-transcriptional modifications of the androgen receptor. There can be somatic genomic alterations that occur due to mutational changes within important transcriptional cofactors that sort of help guide the messaging of the androgen receptor once it has gone into a transcriptional step. There can be intratumoral androgen synthesis, so that tumors are able to produce steroids using cholesterol over their own pathways. There can be upregulation of other pathways that trigger the androgen pathway as well, which I've spoken about before. So PIK3 is a very important pathway and seems closely associated with the androgen pathway. And then the degradation of the androgen receptor itself can be affected, and that meaning that it maintains the stability over an extended time period as well. And so what are the clinical approaches in managing the androgen receptor and the androgen receptor pathway? Well, there have been multiple publications in recent years using drugs that have shown to be very efficient when compared to standard procedures that we've used in the past in managing the disease. So androgen receptor targeted therapies like enzalutamide, apalutamide, and abiraterone, but there are also very interesting studies taking place, phase 2 trials, that are incorporating other drugs that are associated with the PI3K pathway, for example, cetuximab, which is a monoclonal antibody, and also in conjunction with an mTOR inhibitor, to see if we can change and manipulate the pathways that are necessary to better manage metastatic castration-resistant prostate cancer. And there are some other interesting drugs that are approved for completely different usages. I was talking about changes in the androgen receptor. The figure on the bottom right sort of shows the structure of the androgen receptor, and on the LBD, so the ligand binding domain, is where our drugs that we are using currently dock in and block the androgen receptor. But there can be mutational changes to the AR where that ligand binding domain is missing, and so our drug just doesn't take effect at all. And so there have been some interesting developments on a research level looking at antiparasitic drugs that actually dock on to the N-terminal domain, so the NDT part of that androgen receptor. And the other pathway that I wanted to talk about in particular, because it's so closely associated to the AR pathway, is the PI3K pathway. We've seen that a very important role is the loss of PTEN to drive this pathway, but there are other pathways that are closely related as well. And one of the drugs that was interestingly published recently in a phase 2 study looking at ATK. So if you remember, you've got PI3K, the deactivation of P10 triggers the ATK pathway that sort of establishes the activation of the AR pathway, and this particular drug blocks the ATK pathway, which communicates with the AR pathway. So it was shown to show some benefit in terms of radiological progression-free survival of approximately 2 months when compared to just standard abiraterone therapy for patients that have metastatic castrate-resistant prostate cancer that have undergone docetaxel chemotherapy. And overall survival was a marginal benefit as well of approximately 2 months as well. And so, again, just to demonstrate the complexity of the disease, this is a study, in actual fact, it was a phase 2 trial looking at temsirolimus, which is an mTOR inhibitor, one segment of that PI3K pathway that I've spoken about before, and it showed absolutely no benefit whatsoever. So there seems to be many pathways that are activated, and using single drugs in some of the settings is not appropriate enough to manage the disease efficiently. And so one of the last segments that I wanted to talk about was DNA damage repair in CRPC, because it is a very important topic. We know that the BRCA mutations are not very common, but they do occur in patients that have germline, so born defect of one of the alleles. So you have 2 alleles, one of the alleles is damaged. The risk of developing prostate cancer at an early stage is higher. The risk of it is about 8.5-fold higher than for normal individuals. And in the BRCA1 setting, it's about 3.5 times higher. And so we looked at the distribution. There were a couple of big studies that came out in Cell and also in New England Journal of Medicine. We also did an analysis here in BC, looking at the distribution of DNA damage repair genes with germline defects in the general population. And the numbers were relatively similar. So it's around about 8 to 12% was estimated in the calculations from the New England Journal publication. And for us here in BC, the numbers were slightly lower. So in general, it was around about 7.5% for DNA damage repair gene defects in a germline setting, and about 6.5% of BRCA2. And we know that these patients do poorly on ADT management, because if you have DNA damage, there's a high risk that you can have to one of those alleles. The repair mechanism when you have DNA double-strand breaks is not sufficient to correct errors that occur. And so we've seen when we manage these patients with ADT that they have a very short span to developing CRPC, which was around about 11 months compared to our control cohort, which was around about 20 months. And they also do poorly on AR-targeted therapies, but they do better on chemotherapy like docetaxel. And so this is important because this publication in the New England Journal by DeBona was looking at that second loss. So you've got the defect, the germline defect on the one allele, and there can be a damage to the second allele, and those patients respond well to a certain extent to platinum-based chemotherapy or PARP inhibition, like olaparib. And so can one detect it? Is it a useful tool to use? Well, here in Vancouver, with the liquid biopsy program that we have, we don't need to do tissue biopsying to gain its insight into genomic landscape of metastatic prostate cancer. We can use a simple blood draw, because as the disease spreads and the cells disintegrate, they shed the DNA information into the blood, which is the circulating tumor DNA. And if there is enough of that circulating tumor DNA, we can use that to sequence and identify whether that second hit to the other allele is present, which will line patients up for a very precision management of their disease. And so we were able to show here in Vancouver that we are able to do this. And this is important because it lines patients up for a very particular line of therapy. And this is what we would demonstrate here. We've got that change in the BRCA2, which is significant. And this patient went to have olaparib. And as you can see, the metastases, there was a sign of improvement under the management of this very specific precision therapy. And so in summary, what I would like to say as a take-home message is genomic profiling is a very useful tool. We don't have all the insights that we need to manage patients efficiently, but it can be used as an addition to the information we have today in a localized setting. In a castrate-resistant setting, where we have a lot of information shed into the blood and we can use to genomically analyze patients, it shows that precision oncology is on the rise. And although we may be at the very tip of the iceberg, there is a lot of information that we've gained in a very short time. Thank you.